Inside a single drop of blood from a routine lab draw, we see exactly why standard endocrinology has misdiagnosed male androgen deficiency for decades. Legacy guidelines treat the total concentration of testosterone in the blood as a direct proxy for how much hormone actually reaches the body's tissues. This capillary bed diagram reveals compartmentalization. Most testosterone binds to massive SHBG or albumin, leaving a tiny free fraction. SHBG tightly traps testosterone during transit, rendering it inert. Conversely, albumin easily releases its payload, combining with the free fraction to create active bioavailable testosterone. The clinically meaningful exposure for a patient is exclusively this bioavailable pool. Diagnosing androgen status based on total concentration alone is mathematically and biologically deceiving. The decline in male reproductive function over time involves two simultaneous biological mechanisms. Surviving testicular Leydig cells lose their steroidogenic capacity, while the central hypothalamic pituitary axis loses its orderly, rhythmic pulsatility. This graph plots age against total testosterone, dropping mildly after 30. Conversely, SHBG production increases steadily. As rising SHBG sequesters more hormone, actual bioavailable testosterone plunges drastically. This creates a widening, deceptive gap between total blood concentration and what reaches the tissue. On top of this intrinsic aging process, environmental factors have further depressed baseline testosterone in recent generational cohorts. A doubling of SHBG, which is common in older men, can keep the total testosterone number within a normal laboratory reference range, while tissues are effectively starved. As a result, men with severe clinical androgen deficiency routinely pass standard laboratory screenings undetected. Because SHBG acts as the primary hepatic gatekeeper of androgen availability, its regulation requires strict clinical surveillance. This clinical dashboard maps out the variables controlling that gatekeeper. On the left, we see the pathological and physiological factors that actively raise SHBG, creating false normal total testosterone readings. These include aging, subclinical hyperthyroidism, oral estrogen exposure, hepatic cirrhosis, and severe caloric restriction. Conversely, hyperinsulinemia, visceral adiposity, and type 2 diabetes strongly suppress hepatic SHBG. Low SHBG is an independent biomarker for these metabolic dysfunctions. When a lean older patient presents with elevated SHBG and symptomatic deficiency, the immediate priority is addressing the underlying metabolic drivers through targeted, non-pharmacologic interventions. Clinicians counteract the catabolic state that raises SHBG by prescribing resistance training protocols paired with a dietary protein intake of 1.2 to 1.6 grams per kilogram of body weight, while also correcting any subclinical hyperthyroidism. Effective treatment of the hypogonadal phenotype requires managing these upstream modifiers first. Without that baseline correction, clinicians are chasing biochemical noise rather than addressing the root metabolic driver. When shifting from laboratory biochemistry to clinical presentation, the syndrome of late-onset hypogonadism is highly heterogeneous. Out of dozens of potential complaints, large population studies have isolated two clinical signals that reliably track with true biochemical androgen deficiency: reduced sexual desire and the loss of morning erections. Symptoms like generalized fatigue, low mood, and isolated erectile dysfunction are diagnostically weak. They are heavily confounded by underlying vascular disease, psychological factors, and medications, and they rarely respond to androgen restoration alone. Once specific symptoms are identified, the diagnostic process must overcome a major measurement challenge, as standard laboratory panels routinely utilize flawed assay technology at the low concentrations that matter most. This flowchart illustrates the correct diagnostic pathway. Liquid chromatography tandem mass spectrometry, or LC-MS-MS, is the mandatory reference method for measuring total testosterone accurately at low clinical thresholds. Direct analog immunoassays for measuring free testosterone are unreliable. They produce severe inaccuracies, particularly in patients with abnormal SHBT levels, where precision is required. Instead, free testosterone must be physically separated via the gold standard equilibrium dialysis, or calculated accurately using the Vermalion formula, which directly combines the high-quality total testosterone and SHBG inputs. Accurate diagnosis requires the strict marriage of highly specific sexual symptoms with advanced mass spectrometry, eliminating the noise of generic fatigue and legacy immunoassays. For years, clinical resistance to restorative testosterone therapy was driven by observational data from 2013, which incorrectly linked exogenous hormone use to major adverse cardiovascular events. That narrative shifted in 2023 with the publication of the TRAVERSE trial, the largest randomized cardiovascular safety study of testosterone replacement ever conducted, tracking over 5,200 high-risk hypogonadal men. This recreation of the trial's Kaplan-Meier curves maps the composite primary endpoint of cardiovascular death, myocardial infarction, and stroke. Over a 22-month follow-up, the lines for the testosterone group and the placebo group remain nearly perfectly overlapped, confirming strict non-inferiority. Based on these findings, the FDA issued a class-wide labeling update in 2025 that officially removed the boxed warning regarding major adverse cardiovascular events. The data surrounding prostate safety point to a similar conclusion. Under the androgen receptor saturation model, receptors fill up rapidly at normal physiological levels, meaning restoring testosterone poses no additional risk of cancer progression to a healthy baseline prostate. However, replacement therapy does carry distinct, proven clinical risks that demand stringent monitoring, specifically testosterone-induced erythrocytosis, or the overproduction of red blood cells. The absolute clinical threshold for this condition is clear. A hematocrit reading above 54% triggers an immediate dose reduction or a change in the formulation of the therapy. Physiological restoration is cardiovascularly neutral and prostate safe. The focus of clinical risk management has moved away from fearing sudden cardiac death toward the active management of blood viscosity. The therapeutic target of restoration is to titrate the dose to achieve mid-normal bioavailable levels, overriding the clinical instinct to target total testosterone, especially in patients with elevated SHBG. But we must account for the physiological consequence of exogenous therapy. As this microscopic view shows, introducing external testosterone causes a pulsating neural signal to abruptly shut off, dimming and shrinking the surrounding tissue cells. The biological mechanism behind that shutdown is a negative feedback loop. Exogenous testosterone suppresses the release of luteinizing hormone, or LH, from the pituitary gland, removing the primary stimulus that keeps endogenous Leydig cells active. This creates the intratesticular problem. Healthy spermatogenesis requires local testosterone concentrations 50 to 100 times higher than what circulates in the systemic blood, an environment that collapses without the LH signal. The clinical solution for younger men, or those wishing to preserve their fertility, is the concomitant administration of human chorionic gonadotropin, or HCG. This diagram illustrates the mechanism of HCG. Acting as a direct LH analog, the exogenous HCG molecules bypass the suppressed pituitary signal and slot directly into the Leydig cell receptors, restarting the local production cycle. Low-dose HCG protocols yield excellent clinical outcomes, ensuring the maintenance of semen parameters, the preservation of the intratesticular environment, and the prevention of physical atrophy. Precision androgen restoration calibrates tissue-level bioavailability while preserving the structural integrity of the patient's reproductive physiology, moving beyond the simple replacement of a laboratory value.